Welcome to 2-Minute Anaesthesia in Critical Care. Let's discuss the lymphatic physiology in chylothorax. In this episode, we'll learn how the lymph is formed, transported and returned back to the bloodstream and why the thoracic duct is key in this process. We'll also break down what happens when the system fails, i.e. leading to a chylothorax, a rare but serious condition leading to lymph leakage into the chest. Let's first discuss chyle. The word chyle originates from the Greek term chylos, meaning milky fluid. The term entered the English medical vocabulary in the 17th century, specifically describing the milky, fat-rich lymphatic fluid. Chyle is rich in triglycerides as chylomicrons, giving its milky appearance that fades during fasting and returns after fat intake. It contains mainly T lymphocytes, 400 to 6,800 cells per microliter, and is bacteriostatic. Electrolytes resemble plasma, protein concentrations exceed 3 grams per deciliter, and it carries immunoglobulins and all fat-soluble vitamins absorbed from the intestine. Dietary fats are emulsified by bile. Emulsification increases the surface area of digestion of the fats, which are then broken down by pancreatic lipase into monoglycerides and free fatty acids. These free fatty acids are then absorbed into the intestinal cells, where they are reassembled into triglycerides. Inside the Golgi apparatus, triglycerides combine with proteins to form chylomicrons, which are then released into lacteals. Lacteals are specialized lymphatic vessels in the intestinal villi, which are surrounded by the normal capillaries. Because these chylomicrons are very large, they are unable to enter the blood capillaries, and therefore they travel in the lymphatic system as chyle, passing through the mesenteric lymphatics, the cisterna chyli, and also the thoracic duct. Now let's look at the image on the right. The cisterna chyli is a lymphatic sac located in the abdomen. It's a site of convergence from different points of lymph flow in the lower limbs but also abdominal organs, before it flows into the thoracic duct, which then empties into the left subclavian vein near the internal jugular vein, introducing the chylomicrons and absorbed fat into the systemic circulation. In the liver, chylomicrons are further processed into various lipoproteins. So, what happens when the system is interrupted? Chyle leaks can occur when lymph escapes from a thoracic duct or its branches, often due to surgery, trauma or malignancy. Common sites include the pleural space, i.e. a chylothorax, the mediastinum, the perineum and neck. Causes vary by location, but often involve the thoracic or abdominal surgery, lymphoma or congenital defects. The chylothorax is an accumulation of chyle in the pleural cavity, typically caused by damage or obstruction of the thoracic duct. With a daily chyle production of around 2.4 litres, significant fluid can build up rapidly. It may result from traumatic, i.e. surgery or injury, or non-traumatic causes, such as malignancy or lymphatic obstruction. Note, malignancy is a leading cause of non-traumatic chylothorax. Diagnosis involves imaging, especially a CT scan, but also fluid sampling. Definitive diagnosis is made by pleural fluid analysis showing triglycerides greater than 100 milligrams per deciliter and a lymphocyte-rich profile, with lymphocytes comprising approximately 80% of white cells. Further fluid analysis includes total white blood cell count and differentials for confirmation. This image shows the chylothorax due to Hodgkin's lymphoma. The chest X-ray shows a moderate right-side diffusion, anterior mediastinal mass with midline shift. And on the right image is obviously chyle. Chylothorax management can be split into conservative medical and surgical processes. Conservative, i.e. the use of a low-fat diet, which may progress to the use of TPN if clinically indicated, in addition to other medical options. Medical treatments also include the use of an insertion of an intercostal drain to drain the chyle, but also the use of octreotide to reduce chyle production and additional nutritional support to replace lost proteins and vitamins. If conservative medical therapies fail, surgical options may be indicated, i.e. thoracic duct ligation, but also pleurodesis to close the pleural space. Addressing the underlying cause like trauma or malignancy is essential to improve outcomes and prevent reoccurrence. Once again, thank you for listening.